He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Hey folks, welcome. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. We are joined today by Dr. Robert Whitfield. And I got to thinking about it, Phil. We've had a handful of surgeons on, but never anybody, as best as I know, I mean, I'm a medical idiot, but never anybody engaged in the kind of medicine as a surgeon as Dr. Rob. I'm really looking forward to this. I'm not going to do any further introduction than that because I kind of want you two guys to go at it.
Yeah, no, I'm certainly excited for this conversation as well. Dr. Robert Whitfield is a renowned plastic surgeon, and we, like you said, maybe not intuitive why we'd be talking with a plastic surgeon with our focus on kind of metabolic health and lifestyle, diet first approaches to health. But one of the things that certainly grabbed my attention about Dr. Whitfield is, I think I saw it somewhere on his website or in his media kit, that he bridges the gap between aesthetics and mitochondria. And I knew that was going to be right up our alley. Rob has some unique, I think, focuses that are probably pretty germane to our audience as we think about the various toxic exposures, maybe outside of our food, that may play a role in poor health. Excited to get into this. Rob, why don't you give a little bit of your background to our audience? Talk maybe about what got you interested in plastic surgery to start with, and then maybe why you sort of ended up in a non-traditional plastic surgery role.
Sure, thanks for having me. I started out in a very traditional route. I wanted to be a pediatric heart surgeon, and I went a very classical route and did 6 years of general surgery. Within that 6 years, I did a year in the lab, and I got involved in a more of a vascular surgery project that led me to do more and more with microscopes. And I really became enamored with microsurgery that way. I already was very interested in vascular, obviously interested in doing hearts. And basically after that, a couple of different experiences kind of led me down the oncology route. So I pursued plastics to do microvascular reconstruction for head and neck cancer, sarcoma, and the most prevalent cancer, breast. I did the deep flap reconstruction, started in 2004. And I did a microsurgery fellowship. So mine was more of a very specific route in oncology. In 2016, we had a breast cancer patient who wanted to have a flat closure. For the audience, you can have...
Yeah, you got to spell that out for us.
Yeah, so a flat closure is if either Dr. Phillip or I did a mastectomy as general surgery trainees, we would just close the wound because that patient had chosen to not have a breast reconstruction, which is totally everybody's choice. And then making think of like the ends of the incisions more aesthetically pleasing, not leaving any standing tissue, any unevenness. And that's more of an aesthetic flat closure. And then obviously if somebody's doing a skin sparing mastectomy, which means they're just working around the circle, the areola, the pigmented part, then it's far easier to do a more aesthetic closure versus a wider or a elliptical type incision that was done routinely when I was in training. So in 2016, I did this case, and I was trained a very specific way. Anytime I took down a reconstruction, I did a complete capsulectomy. I cultured all that tissue, which means think of like a Q-tip swab. You'd wipe around the cavity, put that into a tube, and send that off the lab where they would incubate it, the same way it's been done since the 50s. And then we, of course, sent everything to the pathologist to make sure there was no recurrent cancer. And in this patient, they had no recurrent cancer, which is obviously first and foremost, but they had, based on laboratory analysis in a hospital, mind you, so like for everybody listening needs to understand this, that means there's 10 to the 6 or over 100,000 bacterial colony forming units per high power field. So when you look at a microscope, you see all these bacteria. So it's quite striking to get her results back, and she had an E. coli infection. So she was walking around with a clinical E. coli infection the way we understand it. I went back through all of my notes and I looked at all the studies and I was like, how did I miss this? My sister recently passed away from breast cancer. I would have been really pissed off at somebody had they missed an E. coli infection on my sister. So there were no, and this is the rub with all of this, as you would imagine, there were no signs or symptoms. She had no redness. She had no evidence of capsular contracture, which is firmness around the implant. She had the basic one symptom that now just kind of, when you think about it, makes sense, but happens a lot in patients who've had chemotherapy or radiation therapy due to bone marrow suppression. They have fatigue. It's very common. So I told her this is an E. coli infection, and they, in the traditional hospital setting, had created an antibiotic sensitivity pattern. So Dr. Philip or I could just prescribe an oral antibiotic for this. So we did, and did that for a couple of weeks back. And what do you know? All of her fatigue was gone. So she, in fact, put me on some Facebook group that I did this type of surgery. And then I just had patients start calling my office wanting to have their implants removed, whether they were cancer patients or cosmetic patients. Now, predominantly over the last 5 years, it's just been cosmetic patients.
So this, you didn't intentionally head this direction. It kind of presented itself to you.
I always preferred autologous reconstruction. So the first kidney transplant was done by Joseph Murray in 1962. He took a genetically identical twin kidney and put in the other twin, and it worked for a year. So why can you do that? Because they're genetically identical.
Right.
If you do a non-identical twin transplant, you have to give them, and they gave the non-identical twin, I think ionizing radiation was how they treated it to immunosuppress the response that the patient would have to the organ. And then the next step was cadaver, and you have to give azathioprine. That was the first immunosuppressant drug, along with steroids. So your body will tolerate only self, meaning from the time you're born, your T cells from your thymus recognize it's called your major histocompatibility complex on the dendritic cells and all sorts of other cells in the body. And they basically tell you when something's foreign. So now fast forward, we have I published a big study last year of 694 consecutive scar tissue explant specimens, meaning the patient's scar tissue was sent off for PCR analysis, and 29% have bacterial contamination, predominantly with Staph epidermidis, which is found in our skin, and Cutibacterium acnes. Now, the important thing about...
Slow down. What was that last one?
Cutibacterium acnes.
And what does that mean?
So it's just a skin bacteria.
Okay.
It's found in high concentrations on the face, neck, shoulders.
So almost 1 out of 3 of these patients, they're
explanted, have that. So then that should make you wonder, like, that's a very high number.
Yeah.
So there's 2 very specific things about those 2 bacteria. So everybody knows what plaque is on your teeth. So that's biofilm. That's the original biofilm. Both of these organisms readily produce biofilm. So they are very hard to eradicate. Your body's own surveillance system, the immune system, has difficulty eradicating this. Now, there's this conception about scar tissue. I think people think it's like a bomb shelter and it's impervious. It is far from impervious. It's more like something that's been woven or crocheted or something. You stretch it open, there's interstices, kind of like a screen door. So the signals from the bacteria that are in the scar tissue on the implant can now interact with the breast tissue. And they do something a little naughty. It's an oxidative reaction. So you always want reductive reactions because that's better for you. You don't want more oxidative stress. So what happens is the interaction between particularly Staph epi and the fatty acid oleic acid in the breast tissue. So everybody's heard of fatty acids. There are fatty acids in the breast tissue. There's a lot of fat in the breast tissue, actually. It oxidizes it. So they give it a fancy name and they call it oxylipin, which is fat, tenhome. So if you just track this through the system, ultimately you get to the end of all of the immune cascade, if you will, and it causes macrophage polarization. Long story short is it ramps up symptoms of chronic inflammation. Those symptoms can vary from muscle pain and joint pain, shortness of breath, dry eyes, dry throat, just a whole host of what you would consider just really vague kind of inflammatory symptoms. And so that's
I'm going to ask you, it's probably a stupid question, but I know there's listeners who are thinking the same thing. So the scar tissue was from your explant
your
patients.
tissue. Yeah. Yeah. The patient's tissue.
So the first thing that I think is, okay, are women who are getting implants, do they have it before the implant happens? Is it, what's going on? Is it, is
Yeah.
the
Okay.
only reason you found it because you did the explant, or have we gone deeper and found that this is going on?
There's three ways to get bacterial contamination. They're very classic. We'll go over them. I'll just
Okay.
wrap up. When you have this, now this is the first time ever there's actually been a research protocol show that this happens.
Oh,
So
okay.
it's a true serum biomarker, and we introduced the scientists who found it to a laboratory company so that they can work to maybe bring this commercially available to the public. Because everybody asked me, is there a test? So
Yeah.
in short, there's not a commercially available test, but I just told you that in the research environment, there actually, in fact, is one. And in those folks who are affected in that way, they may in fact show you that they have an elevated level of that oxylipin, and there's other oxylipins. So then your question was like, how do they even get that? All right, so Dr. Philip and I have operated for a long time. Anybody puts in any object, foreign object, tube, graft, whatever, breast implant, hip implant, knee implant, the staff can contaminate it, giving it to the surgeon. The surgeon can contaminate it upon placement. Those are super low. The rest is life. Somebody gets a cold, somebody gets a cut, somebody has their teeth cleaned, somebody has a colonoscopy, pneumonia, whatever. I mean, you get bacteremic basically, and this gets in your bloodstream, attaches to the device, and the device can't be surveilled like your other tissues.
Yeah, our immune system, right, is supposed to be able to deal with this challenge. And normally, let's say you cut yourself and you get some bacteria under your skin and into your bloodstream, and the immune system takes care of this so that we don't all die from minor injuries. If it becomes sometimes, right, the immune system obviously doesn't work well, and someone might end up with a infection, right, around a wound of some sort.
Right.
And you go to the doctor, and typically you're going to get prescribed antibiotics, and the vast majority of the time that will take care of it. What you're describing here is a situation where when we have a foreign body within our body, like the breast implant, this system has gone a little bit awry in that this infection doesn't reach the point of being an obvious infection, right, that needs to be taken care of, but turns into this low-grade sort of chronic, basically immune response. And you might say autoimmune response because you're reacting to something within your own body, although it is maybe not quite that because it's a foreign body within you. But the body can't quite clear it, but it also doesn't become an overt infection. And it now has this constellation of symptoms that, quite frankly, doctors oftentimes don't put together. You have a woman and she has these complaints, and like you said, maybe this is a cancer patient that had chemo that they're attributing to the chemo, or maybe this is a woman who's getting into menopause and they're attributing it to that, or just it's someone who's got one of these unknown illnesses that doctors can't figure out, and they haven't done a good job of recognizing that it might be due to the implant.
I think the immune system is one of the most poorly understood systems we have. So it's very complex. And when we were in training, I mean, I trained in med school 92 to 96, surgery from 96 to 02, plastics 02 to 04. I mean, a lot of things have happened. The Genome Project happened. So we look at functional genetics a lot. And about 83% of my patients have difficulties with SNPs in either their antioxidant pathway, which is governed by SOD2, certainly in their glucuronidation systems. They have a lot of trouble, either zero copies of something called GSST1 or GSTP. So there's lots of limitations in addition to the standard methylation problems everybody knows about and hears about, because those are all bantered about a lot. And then certainly there's lots of problems with vitamin D, which is very important for immunity. But in these patients, they're experiencing, and you mentioned autoimmunity. So I'll go back to the transplant story. So I used to do deep flap reconstruction. So think of they did this in identical twins. So they took the abdominal tissue of one patient and transferred it to the other twin to do a breast reconstruction using microvascular technique. So that's basically, quote unquote, if you want to think of it, an organ transplant. You have different types of tissue, you hooked up the blood vessels, you reestablish flow. So an autologous transplant. So why does that work? Because it's genetically identical. Now, everything after that, as we talked about, needs a level of immunosuppression, and your body's going to react. Now, in July, a paper was published out of Denmark, and they looked at thinner scar tissue capsules and thicker scar tissue capsules, because there's been this subjective grading system since 1975 about the feel of those. And it was a fascinating paper in that it looked at the thicker capsules, and it tried to, using transcriptome analysis, which means they're looking at the RNA product, the actual RNA, like what's being produced. And they showed that it's far more B cell, plasma cell response than T cell, which T cell response has always been in the plastic surgery literature, basically due to the breast implant associated anaplastic large cell lymphoma, which is a breast implant cancer, basically. It's governed by a big T cell response, and you get this lymphoma. So now, if you follow along, what's happening at the tissue level is more akin to a cadaveric kidney transplant rejection episode, or just an organ rejection episode, because a T cell response would be more of a foreign body type reaction, but a B cell antibody response is more, oh, we need to get this out. This is an organ rejection type picture. So that's a much different, never before understood situation. And it's not perfect, of course. If you get too much tissue on a specimen, it's going to skew the results. But for the first time, they showed this. So all that makes sense to me, though. If you take something that's not genetically identical, not from your own body or not from an identical twin, and transplant it and hook it up, that's why fat transfers work. So it's your own genetic material. So those are all fine. But every time you step away and you're not using self, you have tolerance, right? You can only tolerate whatever it is based on what they're giving you. And I often, Dr. Philip, I'll have patients come and they're like, they didn't know what to do with me, so they put me on steroids. And I ask them, I go, did you feel better on steroids? And they say, oh, just for a little bit, and then it went away. And so that's your tell right there. They're having a big immune response. And that's just like throwing sand at the beach, because whether it's a rheumatologist or a derm or whatever, they're never going to give you the dose that we would give to a transplant patient. They would never give you a gram of solumedrol and just say, all right, you're fine. Because if you're listening to me, that's exactly what those folks would do best with, would be a much, much bigger dose, because then it would just block the reaction. But so at the tissue level, we have a lot of immune system activation. You get a lot of, it affects every system around the body. So it's been a very interesting problem to work on. So we have this program, we look at their genetics. We use Vibrant Wellness for our total toxicity burden testing. And then we've used the Gut Zoomer recently for just stool testing, which is a whole nother topic you could go into for hours. And then we do look at food sensitivities, and we try to gauge some other inflammation scoring indices, but there's no perfect inflammation scoring system. It is like in evolution, so to speak.
I guess what you're getting at there is the theory is that the women that get this, right? Because not all women that get breast implants get this. So I guess my first question is, how high is the incidence of this? What percent do you think get it? Because like we've been talking about, this is something that's not fully recognized. But it sounds like what you're trying to get at is, what are some of the either underlying risk factors that these women may have that predispose us to this, or what are the resultant effects that it's not just as easy as take out the implant and you're done with the illness?
Yeah.
That's not going to work. So I have many patients get, and we'll go off script for a second. Eric Topol published a big paper called the Welderly Study. And they looked at patients who were in their, I believe, 7th, 8th, 9th decade of life, who did not develop end-stage disease that you would associate with inflammation, like Alzheimer's or cardiac disease or pulmonary disease, like emphysema. And so they didn't have a quote unquote longevity gene, which makes sense. To me, I know our genetic archetype. My patients don't detox well. So we put a IRB together. We just got his data set, which is huge. And we want to compare our patients, because about 83% of them have just multiple pathway problems, to that patient population to show that. And I think if you live 7th, 8th, 9th decade of life, you probably have a pretty good detox system. And other things, right? You didn't get exposed to maybe a bunch of glyphosate or phthalate or organophosphates growing up or whatever. And you try to eat well. Maybe you pay more attention to your air quality, which is a big problem in Austin, Texas, where I am. We have a lot of problem with mold and oak and cedar in the air. And then groundwater is terrible just about everywhere in the country. So you got to be sensitive to where you are. If you're in New York, you got to be careful with ground. I mean, like everywhere, you have to be careful with groundwater. And those are just some basic things that we do, and then combine that with all the testing to show that not everybody's going to have a problem. But if you have this genetic archetype and these environmental stressors and XYZ, then yeah, you're going to have a problem. It's multifactorial as usual. It's not just one thing.
Yeah, I guess we previously had Dr. Andrew Campbell on, who talks a lot about mold illnesses, but also started to notice a significant overlap between mold illness and breast implant illness. And I forget the exact statistic he gave us, but one of the studies that they had done showed that a large percentage of the implants, when you remove them, if you do it the right way, you can grow, you can show mold in them. You can grow mold in them. There was mold already in them, I should say.
Yeah,
you just have to culture it.
Yeah, I published that PCR test because I don't like that, as it's a fear-mongering thing to me, because to have a fungus around an implant, which we've had 5 in a couple thousand, the predominant PCR tested species grown is literally Staph epi or Cutibacterium acnes. It's in our paper with over 690 consecutive samples. And then Methuen Sina published a big paper as well, same type of information. And then another paper was published out of a society where they had a much higher rate of bacterial contamination, but it was a much smaller sample. So it's typically, as you would expect, going to beat bacteria. Now, that is scar tissue in patients. So we didn't suck any fluid out of any device and culture the fluid. Now, if they're saying like, oh, old saline implants, we cultured the fluid and it showed this, we have no information on that, because I took out devices that were intact, and if the shell's not off-gassing or not permeable, it shouldn't be leaking. If there's some kind of mycotoxin, it shouldn't be coming out of the device.
Okay. And going back earlier, do you have any idea what percentage of women with breast implants have this? If you screen them carefully enough, I guess is the question.
Are going to have signs and symptoms of chronic inflammation? Is that the question?
Yeah.
I think if you had probably a very specific tool to measure that, you would be surprised, but we don't. I know genetically about 83% have those SNPs, and we do see a fair amount of toxicity burden on we use Vibrant Wellness, like I said. And to be honest, it's kind of predictable if you just listen to them in an interview. The way they feel and what they're describing is they can basically tell you they have pretty limited detox, and you're almost like looking at exclusively at my patient population, a big discrepancy where generally about 36% of the population has MTHFR.
That's a genetic marker?
That's a methylation gene mutation that we've basically, if you have it and you're homozygous or heterozygous, it can take you longer to recover from a strenuous exercise session or a cold or a flu or whatever. Think of it like that. You stay inflamed longer. And so that's virtually 100% in my patient population.
Oh, okay. No, is this because they're self-selecting to get to you?
Yeah, so he's asking the question, but I only see this patient population.
Yeah,
I
yeah.
don't have an epidemiologic study. This is not the biobank study in the UK. We don't have that flexibility in the United States. So these are all people coming in, already decided to do this procedure. I try to arm them with all the information they need preoperatively to make the better choices about their lifestyle. And we run it. A lot of people want a homeopathic detox program, so we use Cellcore for that right now. And we have other options because people don't want to take antibiotics or don't want to take antifungals or don't want to take medical grade binders. Now, I will say that if somebody wants a fat transfer for me, there are very specific criteria to get in my ecosystem. You cannot be taking a GLP-1 in the last 6 months and want to come get a fat transfer. So for everybody listening, GLP-1s work. That's semaglutide, tirzepatide, and there's going to be more effective ones coming. So that combination, which you can order off the internet now and just get compounded and sent to your home, absolutely makes no sense. Those drugs work. Most powerful drugs in my career that I can think of, they change behavior. So they work because his biggest problem and your biggest problem always is changing someone's behavior, making the right lifestyle choices and doing the right things. So this actually does that for you. Now, if someone's got a bad mycotoxin test, like a high burden, we're going to run them through hyperbaric 1 to 3 months pre-op, 1 to 3 months post-op. We're going to put them on an antifungal, usually itraconazole. We're going to put them on a medical grade binder if they want a fat transfer. There's too much at risk for an autologous tissue transfer if you're not being very aggressive about upfront taking care of the problem. Like you can't get the problem right in front of your face and not do anything with it. And it's not going to be changing their diet and getting them a different air filter and remediating their homes. You know, you never know when they got exposed to mold. That could have been in college. It could have been where they grew up. Maybe they grew up in the Midwest and the basement flooded. Who knows?
One of the questions that occurs to me, and again, remember, I'm the medical idiot here, but that's most of our listeners. Is there any differentiation that you've seen in the women who are getting this breast implant infection? Is there any differentiation between those who get the implants because they had a mastectomy and they just want to have it rebuilt, and those who just got it for purely cosmetic reasons?
Oh, you're always going to have more problems in a cancer patient. They have more surgery. So that's not a fair comparison.
Okay. So a listener who's sitting here thinking, I gotta have a breast implant, things aren't quite right with me. How do is there a way to do kind of a self-screening to see if they need to go deeper into this particular possibility?
I tried to introduce some basic inflammation testing, but most of this is kind of very, if you will, history based. I think one of the things that frustrates me is when I get a patient who's clearly not doing well from either a GI standpoint or like overall health standpoint, and you talk to them and you ask them like, okay, you do the history, like where did you grow up? What kind of work have you done? What kind of foods do you eat? And then I'm like, where have you traveled? And I say, a lot of people in Texas go to Mexico. And if you eat off property, it's a pretty high chance you're going to get a parasitic problem. If you are a missionary and went to Africa on a mission, or all these different opportunities to introduce parasites, it's parasitic infections to me are frighteningly common, but hard to deal with. I see them routinely, and same malaria is a parasite. Toxo comes from cats, it's a parasite. I think I got really attuned to mold about, I guess it was about 5 years ago now, but patients with high mycotoxin burdens or if you want to think of just mold toxicity, they have a lot of trouble with memory, a lot of trouble tracking when you're speaking to them. And it's very sad to have these young folks who have kids, who have jobs, who have families, not be able to follow what you're saying. And they have trouble like with almost like synthesizing what they're going to tell you. They may have trouble remembering their kids' names. It's really bad. So we do all this workup, and I try never to minimize how it's affecting each individual patient we see because everybody's immune system is very different. Everybody's exposure is very different. Nobody can pick their parents. You get your genetic makeup from your parents, and then it's a combination of stress and environmental factors and food we eat, air we breathe, fluids we drink, how we sleep. I make a big deal about sleep. Most people just kind of ignore sleep. You can't even recover from a case if, in fact, you don't get enough quality sleep. And then I have my patients come to the office the day after surgery, which is probably not very normal around the United States. And I see them, or our team sees them, and I tell them, like, you got to get your cortisol down. So look in the sun when you come to the office, and then come inside. And we have a hyperbaric chamber that's vertical, so my patients can just sit there and not tax their chest by pushing up and pushing down, because we're doing chest surgery. We have something to help lower sympathetic activation called the human regenerator, it's a fascinating thing out of Germany. It uses cold plasma. And all I can say is, I think we need to learn more about physics and energy-based tools that we didn't really get in school, because it would be nice to leverage more practical things. Like, the people who seemingly leverage physics the most are like radiologists. Like, they're constantly using physics and planning, but we don't really leverage that. And so we have this device in the office that's more akin to that. And we leverage lymphatic massage. So we have these devices from New Zealand called Filopresso. So when we're I don't use drains. So a lot of extra fluid will build up either from the day or from where we operated. And so we have them come to the office and get a lymphatic massage. And then we have other wellness things. We have a big 6-foot tall red light. I mean, we have all the kind of basic things and a few special things we like.
Okay, that doesn't sound basic to me, Phil. It sounds like he's now, and full disclosure, Rob, my personal physician for the last 20 years is a naturopath. So I'm totally down with the non-pharmaceutical solutions to everything. But I'd love you to expand on the use of these non-traditional solutions, why you're doing it, what the effect is, what patients can expect, and to be honest, questions they ought to be asking their own doctors.
Well, it's basic. I think I was trained. I had great mentors. They were actually trained during the wars, like the Korean War and the Vietnam War, and they were around at the time when IV nutrition, or nutrition in a bag, was invented. So when we would, in training, they would be like, "All right, Rob, how do you want to make the bag for Philip?" And you'd have to know exactly how much to put in the bag for Philip, and how much fat, how much protein, how many electrolytes, all the things. And if you didn't, they would just torture you. And it wasn't about you becoming a great surgeon. They felt they were going to get that. You had to be a very sound doctor. Like, you had to take care of patients properly. And then when I got done with general surgery training, I went into plastic surgery training, where I trained in Indiana. The campus was the regional burn center, and the burn center was ran by the plastic surgeons. So it's not like anything got less complex. Outside of a liver transplant patient, the sickest patient you'll ever take care of is a badly burned patient with an inhalation injury. Their needs for nutrition are through the roof. Metabolically, they're ramped up. And yeah, you had to learn how to do nutrition. And so when I hear people talk about protein, it's kind of comical. I'm like, yeah, I mean, of course, protein's important. So we leverage that heavily in our practice. And I have these discussions now. In the Western diet, especially women's Western diet, it doesn't have a lot of protein. And with the advent of so many people taking GLP-1s, either macrodosing or microdosing, they're causing themselves a problem. And I'll put it this way. Your lifespan as a woman or male is directly related to your thigh strength. And to maintain your thigh strength, you better be doing something heavy. So if you're sedentary and you're taking that drug because it helps you lose weight, you're doing two really bad things. You're ruining your skeletal muscle mass and your fat layer. And so
Your fat what?
Layer.
Oh, your fat layer. Okay.
Yeah. So you'll see, you've heard of the Ozempic phase.
Oh, yeah.
Yeah. So that's a real problem. So you can't get that back. You have to then go get an operation or an injection to put volume back. Anyway, my point is, we spend all this time talking to patients about nutrition. I don't ever talk to people about carbs at all. So all I care about is, and my benchmark is 100 grams of protein in a given day. And everybody's, oh, I can't get that much, and I can't do this, and I can't do that. And my dad was old, and he's like, can't diet and bury himself. He used to tell me that when I was a kid. So I always tell them, like, you should try to do a 3-2-1. Stop eating about 3 hours before bed. Stop drinking about 2 hours before bed. And then about an hour before bed, get all the screens and junk out, get the room cooler, sleep mask, noise, whatever you need to get it sorted out. But on that last drink of fluid, I emphasize just drink filtered water. Put 15 to 30 grams of, and we use like a vegetable-based protein because I got to have something works for everybody. And I was like, hey, just drink this. By the time you wake up in the morning, you will have fasted 8 to 12 hours, depending on how long you were asleep. You'll be dehydrated. And this is when your body rests and repairs and recovers. So in the morning, I say, all right, just do the same thing in the morning, though. Just add a little electrolytes to it. And now you've gained an advantage, right? So now you're either 40 or 60 grams ahead of the day because you did this. You ended one day and you began another day. So you're already ahead of the game. And instead of, I'm sure Dr. Phillip will remember this in training, we got taught to react to a bunch of things. It was very frustrating. So everything I try to do now is get way ahead of this. Just be preemptive and aggressive on the front end. And the simple question you ask them, Jack, in the afternoon is, are you getting tired in the afternoon? Do you feel like you just have to take a rest? And if they say yes, that's their body telling them they have not increased enough of it's really nitrogen balance, we'll just say protein in their system. Because once they get enough protein in their system, you get in a positive nitrogen balance, your body will start to heal and recover and everything will work. You'll have more energy. And the things we leverage, right? Nutrition, proper hydration, not 9 gallons a day, because that'll just make you more puffy after surgery. And I have to educate people about that. And then we use hyperbaric.
Just real quickly, folks, he did not say you need 9 gallons a day. That was not what he was saying.
No, don't do that. That's absurd, especially after surgery. So we don't give people IVs after surgery. That you don't want to do that. You're leaky after surgery. You want to just utilize your GI tract and get your body doing what it should be doing. So with protein, so you got the right amount of nutrients in the system. And then with oxygen wins, right? Dr. Phillip will tell you more oxygen, the better. Like the only operation that improves physiology is a cardiac bypass. It's great. It's a great tool, right? It increases oxygen, blood flow. So we just leverage hyperbaric because when you increase the oxygen tension in the system, you improve healing. You also decrease the chance for an infection because an infection wants to live in a low oxygen environment. So if you raise it higher and higher, harder to get an infection. Knock on wood, it's super uncommon for us to get a problem with skin breakdown or wound breakdown or nipple problems or anything because we're so aggressive on nutrition and oxygen and all the things in terms of rest and supplementation. We have a very specific stack of supplements we use that are just liposomal because my patients have a lot of absorptive issues. So I don't want them trying to take a lot of capsules or tablets. It's very hard for them to digest those. And I love patients getting a little bit more understanding of their own lymphatic massage. Your body has the best filtration system, most efficient filtration system there is. No drain tube that he could put in or I could put in would ever work as well as your lymphatic system. So we just want to leverage all those things to work in concert so that when we get you prepared properly and get you on the right track afterwards, your swelling goes down quicker, your energy returns sooner, and you're able to, most of my patients spend about a week in Austin. If patients are local, we set up little packages so they can come do more hyperbaric or more lymphatic massage. The more time you can spend with us, the better.
There's a ton I want to dig deeper into here, but maybe just a couple of points to hit on first. During my training as a surgeon, and you probably heard this as well, right? One of the things that differentiates really good surgeons from average surgeons, we'll say, is knowing when not to operate.
Yeah.
So what are some of the things, right? I'm sure you have a lot of women who come in and they have breast implants. They're having all of these sort of symptoms, right? But probably not all of them are actually going to benefit from the implant may not be the problem. So what helps you differentiate when removing the implant is a good idea and when it's not a good idea?
Yeah, it's an interesting question because I don't ever tell anybody to get an explant. Never have. It's not part of my program. So if you've decided and that's what you want to do, we'll let you come into the ecosystem and we'll interview you and talk to you about what options are available and see if there's alignment. But nobody goes through the process now without getting worked up. And our workup's very different. When you and I trained, it was like a chest x-ray, EKG, some blood work, and a pregnancy test. So yeah, all that stuff better be fine, or you're not going to have outpatient surgery with us. But we're looking at their genetics and toxicity burden and gut health. And those three things really dictate when and where you can do something. Because a lot of people are not ready to have this done. It's more of a psychological problem, a logistical problem, a resource problem, and they're just looking for help because they haven't been able to find help.
Yeah.
Our program definitely can lower inflammation given our experience. And then if someone has because we don't have that biomarker yet, so I can't say, oh, if we do this program for this long and then see how you're doing, maybe we just make a fork in the road and you don't need to do surgery. You can just stay on this program. Now, there was a company that failed and they did thromboxane A2 testing on urine. So it was promising it would show it elevated, but it was very easy to manipulate. If you had ate turmeric or curcumin or something or took NSAIDs, it would affect the result. But if you had somebody completely naive, which we had a teacher in New York, excuse me, and we sent her the test, she did the test, and it was sky high, tiny woman. And I was like, oh, this is perfect. And so we put her on the program and she followed suit. And when she came for surgery, we repeated test day of surgery. And then a month out, we sent her another test. And it had efficiently just went down. And it went down pre-op. And then it continued to go down post-op. It spikes a little bit post-op, of course, and then starts to go down. So we just don't have that kind of metric to say, okay, in this setting with these symptoms, you can run the program and then you don't need to do anything. I feel like there's a whole group of people I can help that way. So we made the program available now. They can run it remote with our group. So I know that it works. I just don't know, like you're asking, like in how many people is that really going to solve it?
Yeah.
And one of the other interesting things you mentioned earlier, I wanted to circle back on, was you alluded to certain of the fatty acids within the breast tissue that seem to be more prone to this oxidation. Maybe dig into that a little bit more. And does that tie back to the types of fatty acids that people are eating or not eating that might play a role in this?
Yeah, that paper was done by Mithun Sina and his group at Indiana University Medical Center. And they showed in one study that oleic acid was involved, but then they got a bunch of different oxylipins and published another paper that had multiple profiles. There's going to be involvement with other lipins. And it's just I think his point was like, we didn't even know this oxidative reaction was happening. And so the more oxidative stress we put ourselves through, the more difficult it is. And these now are linked with the immune system activation, which was kind of puzzling because it didn't make a lot of sense. But with his work and certainly the work of the Dutch group I described, to me, more and more of the puzzle pieces come together and makes more sense.
Okay. I got your press kit from your assistant, and there were some suggested questions in there that one of these I just absolutely love. Actually, a couple of them I love. And I wanted to make sure that we ask them because I'm wildly interested. One beauty trend you would love to see disappear.
Yeah. I do not like people who use too much filler in their face. So facial augmentation with filler is really bothersome to me. I don't like it. I don't like unnatural appearing people.
The other one was biohacking.
Yeah.
Biohacking, any kind of I can't remember the exact question, but the gist of it was the particular biohacking trend you're obsessed with at the moment.
I think what we've tried to do, and we go to the conferences, and I really try to remain very curious about what's coming as it's related to energy-based therapy, sound therapy. I feel like there's a lot of room there to move the needle for patients. So I always want to know what's coming and how can we be helping patients that way. I think it's very short-sighted to think that we understand what's going on very well as it relates to, like we talked about, immunity or energy-based therapies. I think we need to learn a lot more there.
I'm going to go deeper then. There's my son, my oldest son is a pretty hardcore fitness guy.
Yeah.
Has gotten into peptides. And I
Oh,
see
the
that
peptide talk.
peptides,
Okay,
I,
here we go.
I see that peptides, as I've dug into it, I'm starting to see, oh, wow, this is a thing. And I assume it's mostly the gym bros who are doing it. But he was telling me over Thanksgiving about a particular peptide that apparently ramps up the body's ability to fight both bacterial and viral infections. The reason I bring this up is because you've a couple of times talked about energy medicine, and as I understand it, what's happening with peptides is actually operating at the level of our body's energy production system and just helps us do it better. So I was fascinated when I read this, your bio here, and I wanted to see if there's, you know what, I just realized as a surgeon, you probably have to be very careful what you say on this. Can you comment anymore?
Yeah. So peptides are not new.
Yeah.
They've got a lot more attention. So about 7 years ago, we started using them pretty aggressively, and there wasn't good guidance. It's like everything, right? The tool is only as good as the guidance with which, or the experience with which you have to use the tool. So BPC 157, which is an endogenous produced peptide, is a very good peptide as it relates to healing without seeing the specific study that Osama's talking about. I mean, we're just kind of scratching the surface. Glutide and terzepatide are peptides.
But they're artificial. They're created in a laboratory. They're not endogenous.
But they're peptides.
Okay.
They're literally the most powerful drugs ever created. I think that had they known the downstream effects and how much money everybody would lose in terms of Starbucks, dialysis, organ transplantation. I mean, there's trillions of dollars being lost because of those drugs. I dare say they wouldn't have brought it to market. That would not have been in their best interest. I don't think it would work. The ones coming are way better. The ones coming are so much more efficient than those. They're going to be like, for instance, Jack takes this newer peptide, it burns fat and builds muscle. So we're going to have like maybe more of a aged appearance, but a more fitter physique. It's going to be a very strange decade coming once these newer ones come out, because they show these little, I think it's rat studies, and the rats are all jacked up like they've been at the gym the whole time. So the drugs work and they modify behavior. So for us to leverage them a couple of years ago now, or whenever the FDA sent out the letter about BPC 157, we don't do anything sideways with the FDA. I'm not somebody who, I get asked about this all the time by patients. And for everybody listening, if you're ordering this stuff off the internet, there is no third-party validation of what you're using. That means it's not being tested. And so it will have variable responses. And you hear this all the time from patients. I just had a patient in my office and say, I feel great on this. And I said, do you know how much you're taking? And who's guiding it? I was just curious. And she said, I have a call like every month or two or whatever. And then they send it to me, I draw it up, self-administered, not pre-loaded needle. And I'm like, this is just gonna go the wrong way. So then she says the quiet part out loud. She goes, sometimes I take more than my recommended dose.
Yeah.
And I said, and Dr. Phillip will appreciate how I did this. I said, hey, if that were a heart medication, would you just take more? Because you said, I just need to take a little bit more of my heart medicine. Of course not. Like, this is such a bad way to provide or deliver care to me, because there's absolutely no supervision. And those drugs, if somebody's from a quality standpoint, unable to understand what's in the drug. I mean, it's crazy. The compounding pharmacies don't have to do any third-party checks, or they don't. And that's why you get such variability in responses in patients.
Yeah, I think certainly it's an area that's got a lot of promise, but also has a lot of potential bad stuff with all of this.
Yeah.
And listen, that's no different than anything we do in medicine, right? There's always these risks and benefits that we need to balance, and doing that responsibly with your patients is ultimately, hopefully, what most doctors are looking to do. Whereas if you're just sort of dealing with essentially a marketing company, then they might not have those same priorities. And I think that's where we really have to be careful with these things.
All right.
Yeah.
I would feel like I was failing to do my duty as a producer on a show that's focused on metabolic health if I didn't say this. And one of the problems that those of us who are just laymen deal with is the fact that the medical community and the alleged gatekeepers for quality in the medical community have failed us all so spectacularly over the last pick a number of years. But it's become pretty obvious that we're dealing with a deeply corrupt set of gatekeepers. As somebody who doesn't have the inside track on the science and the research, I just sit and pay attention to what's happening, and it drives me nuts that the people who are supposed to be taking care of that kind of stuff clearly don't anymore. And I think that's part of the reason for the explosion, at least what appears to be an explosion, in interest in alternative therapies. I don't even know that I'd love for either of you to comment on that, but I'm sitting here in the role of the listener to the show, and I have to articulate that particular complaint. Crap, man, who do we trust?
Yeah, I mean, I've been asked this question a lot, right? And I trained in a very different era. And I've remained just curious about and tried to look for opportunities to help patients. Now, surgery is a contact sport. It's not like seeing somebody every 5 minutes. And that system has not worked for a long time.
Yeah.
People are frustrated, rightfully, whether it's the level of corruption at the pharmacy manager level or the insurance level, whatever the level you're looking at, it's a mess. The problem is really the access to someone like Dr. Phillip or me or somebody who's spent more time and tried to better understand the alternative therapies or the energy-based therapies or biohacking, whatever we're talking about. I mean, hyperbaric oxygen somehow has become vogue. It's not new. It's been around for ages, but somehow it's just, hyperbaric's a cure for everything, which of course it's not. But people are just going to have to continue to look for and seek out and align with a provider that they feel best with. It's always the same. It's the same thing when I tell somebody about surgery. If you go into a surgeon somewhere and the surgeon doesn't seem comfortable with what you're asking them to do, then you should definitely leave. That is not the person to do the case.
Yeah.
Surgery is a repetition sport. It's the only sport in medicine that you get better at with time until you don't, because it's a repetition sport. So you can get taught well and everything. You don't have that much experience. And then you got to go out, you got to work and get more experience and everything. But like I hear patients all the time tell me like, yeah, I asked Dr. Smith about doing this surgery and he said, it doesn't work. It's dangerous. I'm like, oh, okay. First of all, you just need to get out of Dr. Smith's office. He just doesn't want to do the case. Doing a capsulectomy is not dangerous. And an implant removal, whether it's for cancer or cosmetics, is not dangerous. To say that to a patient is very telling about the person who's saying it. They're either not well trained, not well read, not comfortable from a skill set standpoint, or all the above. Definitely not who you want doing a case.
I think this is a deep
pretty
subject.
good advice.
Yeah.
No, it's just That's it. It's not going to get better.
You've
But
got to,
the robots may come and save us all.
the robots are going to save us. You've got a lot of information on your website. I know that this is going to attract a deep, though narrow subset of our listeners
Yeah.
who are going to want to know more, to do a little self-diagnosis,
Sure.
point folks in the right direction.
Yeah, the way we set up the site is I feel like this takes a lot of time to wrap your head around. There's not a lot of good literature. We've tried to put forth, I think we have about 140 podcasts, 3,000 videos. I wrote a couple books, done some other things, made a bunch of appearances. But the website holds all the keys. If you just want to go there and do like the Netflix and binge type thing, that's basically probably the best. So just drrobertwhitfield.com, and then kind of pick what you want to do. Some people like to listen to an audiobook. Some people like to watch videos. Any of that resonates, there's that option depending on what you want.
drrobertwhitfield.com.
So,
I'll make sure that's linked in the show notes.
thank you.
Phil?
This
How
is
do you wrap it up?
Yeah, this is just a fascinating conversation. And I guess to wrap it up, because roughly half of our audience is female, and certainly not all of them have breast implants, right? So this may seem like a topic that only applies to a small area, right? But I think Rob's broader approach to this problem, right, is what should speak to everyone in our audience. That, because again, this oftentimes gets thought of as a sort of black or white issue, right? You have an implant, you have illness. Okay, if it gets acknowledged, then the answer is, well, just take out the implant and that's going to fix it. And clearly, it's more complex than that. And I certainly applaud what Rob has done to bring in a lot of these, call them what you want, alternative, but I would just say more forward-thinking approaches to this problem. And I think there's a lot that we deal with in medicine that we need to be applying the same thought of the same type of thinking to. So I think that's kind of how we wrap this one up. And thank you, Rob. This has been I found it fascinating, certainly.
Thanks for having me on. I appreciate it.
Good. I hope you two guys get to talk more offline, because I probably felt more lost here than I have in quite some time. Our guest has been Dr. Robert Whitfield. This has been Stay Off My Operating Table with Dr. Philip Ovadia. Subscribe. We have lots of good stuff just like this. And if you're dealing with what you suspect might be complications from breast implants, I definitely, or know someone who is, I definitely recommend you go to Dr. Robert Whitfield's website. Like I said, link will be in the show notes. Thanks for being with us. We'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.